this was actually part of, that you might not know, is that we are the home of the largest longitudinal study of normal human growth and development in the world. And back in 1930, they brought kids in here when they were born, and they studied them until they were 18 years old. Every year they'd come in on their birthday, and this was one of the instruments that they did, and they would measure their heads. 0.7, so you're dollar. Okay, so under 75. So, well, it's 75 to 85. So 75 and under is dolichocephalic, and 85 and over is brachycephalic, and in between you're mesocephalic. So if you want to do it, you can measure yourselves. Who's your class president? Ashley. Okay, so I'm gonna lend this to Ashley. Okay, I'm gonna lend this to Ashley. So anybody that wants to, or you can pass it around if you're bored while I'm lecturing. If you want to take a break, you can quick measure your head. You want to measure the widest part, right? And then this part here, and then you divide the big number by the small number by the big number. All right? So that's enough review from last week. We got to get on to the next thing. So last time I wanted to talk to you a little bit about the big picture, okay? Like faces, what you know about the human face, you know, what you know just from being a human being, all right? And then what I said was we're going to start to drill down and start to learn how we talk like doctors so that we can talk about growth and development, and we use the big words, right? Okay, so we use the big word brachycephalic, right? We don't say fatheads, all right? We use dolichocephalic, all right? We say leptoprosopic, uroprosopic. We get into all of these things, okay? Because that's part of learning to be a doctor, all right? We've got to get the doctor speak down. So, what I want to talk about today, and I'm only going to spend an hour on it because the rest of the class is going to be about the tough stuff that dentists have to know, okay? But I'm going to start with the easy stuff that the orthopedic surgeons have to deal with, okay? So, they deal with stuff like this, all right? The big pieces like this, all right? I was going to show them how they're supposed to kick the ball, like that in football, but this is obviously the long bones, right? The long bones. So we're going to talk about bone growth, and what's interesting about bone is that we can actually have bone that's a tissue, okay? A tissue, and a bone that's a bone. In fact, one of the most famous books about bone is called Bone and Bones. Okay? Because bone can be an organ, or bone can be the tissue, what that organ's made out of. And it's the same. Okay? Bone and bones. So, what's interesting is that the appendicular skeleton, which is like everything else, right? This is his left foot, I guess. We need to get a left-footed kicker. So the appendicular skeleton, everything up until the neck, is just there to carry the head around. Okay? That's the only reason it's there. So pretty soon we're going to just replace that with a robot anyway. So you'll just have your head and everything else will be a robotic probably. So they're now, I just learned at a meeting today at 1 o'clock that now they have robotic things that actually can transmit feeling to your brain. So people that are missing an arm or a hand, they can actually make a mechanical hand, but not only do they make a mechanical hand, but the hand can feel touch. So that's the dimension that's missing. I don't know if you've ever had, this is not going to be on any test, but I don't know if you've ever done virtual reality, and some people when they put on the virtual reality goggles get sick because it overloads their senses, and the reason is you don't have any sense of touch. There's not any feeling, and that's why it overloads you with that. But anyway, that's on another subject. We're going to just talk about bone and bones. We're going to talk about how these bones grow, okay? Now, you need bones because without that we'd just be a pile of jelly. Because bones provide what? If I said bones provide something, you'd say rigid support. Rigid support, exactly. So bones are there for rigid support. And so we need two things. We need rigid support, okay? And then we need some sort of flexible material because we got some things like ears and noses that if they were made out of bone, the problem is we'd be breaking them off all the time. People break their nose enough as it is, right? So we also need another structural tissue called cartilage. And those are the two basic structural cartilages of the human body, okay? Now, the key and the interesting thing about bone is just the way that it's put together, okay? It's got a calcified matrix, So, this is obviously a plastic bone, right? But if we would be looking at just like another bone like this, okay, we wouldn't actually be looking at cells. We'd be looking at the matrix, the hydroxyapatite matrix. So when I'm looking at this thing we call a skeletal bone is nothing but matrix. There's no living cells. The living cells, in your body, right, in your bones, the living cells are encased in this hard matrix. So imagine this. You've got a cell. It's got a nucleus. Okay. And then you have another cell. And it's got a nucleus. Okay. And then these cells secrete matrix that's hard. So they secrete this matrix. And imagine this, I'm doing it in 2 dimensions, but the white is a rigid matrix. It's rigid. Hydroxyapatite's a crystal, okay? The cell is living. Once a cell gets encased by bone, 2 things happen. Okay, 2 things happen. So once a cell, imagine all of you are osteocytes. Now, why do I say you're osteocytes? Because you're encased in these chairs, and the chairs are like the hydroxyapatite crystals that are holding you guys all together. All right, you're stuck. You're stuck inside of this bone. Okay? Now, because of that, in order to live, and you're stuck inside there, cells have to exchange nutrients with the environment. Right? Remember your biochemistry? Did you take biochemistry last semester? Okay, so you remember remember the calcium gates and like how you have to open the membranes, you have to get things out. Okay, so now we're going to bring that to what's the physiologic significance of that, is that in bone, in order to have that happen, see what kind of cool chalk I got. The last time I spilled my chalk all over. There it is. Okay. So what color can we use? Okay. In order to have that, we have to have each cell has to be supplied by a capillary, right? So imagine every one of you as cells there, you have a little feeding tube, and that's the capillary that goes to your cell, and when you produce byproducts, you ship them out in that capillary, and when you need nutrients, it comes in on that capillary, okay? So, the deal is this: once bone is formed like this, and we get all this matrix like that, okay, these cells are stuck inside the matrix. So bone cells, once they're calcified, once you have an osteoblast that now is an osteocyte that has calcified matrix, it has to stay in the exact same position in that bone for its entire life as an osteoblast, an osteocyte. Okay? Yes?
Does the osteoclast come through releasing phosphorus and calcium? Are they also destroying those osteocytes? They chew along, or do they chew
osteoclasts, as you know, come from where? Hematopoietic system, right? They come from monocytes, that they're multinucleated giant cells from the bloodstream, from their blood system. Okay?
Do they chew around or chew through?
Let me just say, there's actually in the book, there's a picture of this. We're going to get to it at the end of the lecture here, exactly what happens. But you're exactly right. Anything that's going to chew through bone, actually the tough part to bite through is the matrix. Right. The cells are gooey, they're easy, right? But when you're going to try to do something through bone, if I'm going to try to do something in the inside of a bone, I not only have to get rid of you, that soft, mushy thing in the middle, but I got to eat through the chairs. Okay? So osteoclasts are capable of dissolving hydroxyapatite and cells, but it's the hydroxyapatite that makes it tough. It's not the cells, because there's lots of cells. So you're stuck in this chair. You're stuck in that forever, right? So the two of you, I don't know your names. What's your name?
Chrissy.
Christy, okay, and you?
Becky.
Becky, so Christy and Becky, and next door?
Abiha.
Abina, okay. So Christy, Becky, and Abina, okay? Forever in this bone, in this room, they're going to be in the exact same positions no matter what happens. There's only one of two things that can happen to them. Okay, they continue to get their nutrients, they stay in the exact same places, or they die. Okay, if they're dead, then I'll show you if they're dead and they're in the middle of the bone like this, we've got a special way to fix that, okay? It's a special way to fix you old dead osteocytes in the middle, and we'll talk about that, okay? So, but on the edges of bone, guess what? On this group right here, the lucky group, right? These people are on the edge. When you're on the edge, it's really cool in a bone, okay? That's the best position. Being stuck in the middle is bad, okay? Because not much good can happen to you. But if you're on the edge, you see anyone that's on the edge, if we think about this, a bone, because bone on the edges, not in the middle, but bone on the edges has a, let's see what I'm going to try to use, a blue baby. On the edges of bone, not only are these, they're osteocytes right on the edge, but just a little bit outside of that, there's a membrane. A membrane. And if it's on the outside of the bone, we call it the periosteal membrane, which means it's periosteum. It's on the outside. And guess what's in periosteum? What? Blood vessels for sure. We have blood vessels inside, and in this periosteum, that doesn't write very good. Okay, we got blood vessels. Okay, blood vessels. What's the cell of bone that can divide? Osteoblasts, exactly. So you've got osteoblasts. Okay, and you've also got fibroblasts, right? Because it's a membrane. So you got fibroblasts, and you've got sort of an amorphous. You know how fibroblasts are. They call them fibroblasts because they're fibrillar, right? And they can secrete like little not cartilaginous, but collagenous fibers, right? Collagenous fibers. So there's collagen. There's collagen in here. Okay. Now comes my favorite part of this lecture. I need to demonstrate someone here that's agile. Maybe this guy, Brian. Come on up here, Brian. I don't know, you're sort of big. You sit on this because you're too tall for me. On the front, sit on the front like this. Pretend you're sitting right here like me. Okay. So, I want you to remember one thing forever and ever when you're a dentist. Okay, forever and ever. Now, if we see Brian, you have socks on. Okay. Okay, good. Right here, right there, I have just a little bit of dermis, okay? And then right underneath that, I have periosteum, okay? So one of the things that's in periosteum that you need to remember is if I just take Brian's and I just even a little tap there, you see, will cause a big bruise and it will hurt. Do you know why it hurts? Because periosteum has nerves. You can put your leg down. I'm not going to hit you. But remember, when you're a dentist, if you touch periosteum with a scaler, you're giving an injection, okay? If you take that needle and you run it along the border of the mandible because you're trying to find the mandibular canal, you don't even know about some of that stuff now, you're trying to get that anesthesia in there, or you take your scaler, you're trying to scale, and all of a sudden you nick, not the gingiva, gingiva hardly has any nerves, but you nick that periosteum, that patient's going to know it the next day. Thank you. Just like that. So remember that all the time you're a dentist, when you're working with bone, anytime you damage periosteum, you're going to have pain, because that's where the nerves are. Okay? Interestingly, if I numb the periosteum, I can drill into the bone and it doesn't even hurt. Because inside the bone, there's no nerves. So when you're doing implants and you're doing that kind of stuff, you need to anesthetize the periosteal surface. A lot of times what people will do is they'll actually take a punch and they'll punch out the gingiva and they'll punch out also the periosteum. And they'll just cut it out because it's cleaner to cut it. Scraping is, like as you can imagine, is what really causes pain. So remember that bone is unique in that it has this covering, and the covering, are you okay? Oh, okay, I didn't think I took it. All right, but anyway, the covering is, I don't have one. All right, we'll find you one. So before I go too far.
You have plenty of extras.
You got it? Okay, thanks. All right, pen's back. We'll get somebody else up here next time. So, but anyway, thanks. So what I was going to say is that this periosteum is dynamic. The periosteum is dynamic. Because periosteum can do two things. Periosteum can actually, because it has osteoblasts, like believe it or not, if you're an osteoblast in the periosteum, you could duplicate yourself. All right? So you people on the edges, you can actually add. Now, unfortunately, once you add someone to your left, in this row, if you add somebody to your left, now you become one of the unfortunate osteocytes. Okay? But that's where they come from. So when bone grows, it has to grow only on surfaces. Only on surfaces. And why is that? Why can't it grow interstitially, we call that? Why can't it grow interstitially? Why can't you get two of you in this chair? Exactly, because you're in your matrix. You know, you guys, you can't, if you tried to divide, you'd squish each other and then you'd be dead. So you're not gonna try to do that. You're not gonna divide, you're gonna be there. You're not gonna be able to divide. If you were able to divide, now, if I looked at muscle, okay, when you build muscle, there's two ways to build muscle, actually. That's probably not a great example. But muscle, you can increase the size of the cells or increase the number of cells. When something increases in the number of cells, that we call interstitial growth. So what can grow interstitially? What can grow interstitially? Give me an example. Josh, you have your name and I can read it.
Okay, skin.
Skin, very good. Give me an example of something that can grow interstitially. I already said it already. Muscle, okay. Is it Alicia? Alicia. All right, muscle. Anything else? What about blood vessels? Yes. What about nerves? Yes. Actually, for a long time, people didn't think nerves could grow, right? But now we know they do. So that's like new news in the last decade or something. You know, fibroblasts? Yes. Okay. The skin of the gut? Yes. Okay. In fact, almost any tissue you would say, you'd be right. Because bone is an outlier. Bone is an outlier. Bone cannot grow interstitially, and it's unique in that way. So most of the time, the way things grow is you increase the number of cells, you increase the size of the cells. But with bone, that doesn't happen. Once it's this size, it can only grow where? On the edges, on the edges, on any of the edges of a bone. On any of the edges of a bone. So, if we look now at this guy, okay, and there's the, right there where we're getting on the periosteum. So, where are their edges? Well, everywhere you see, right? Everything you see here is an edge. Everything you see here is an edge. And there's also edges where you can't see, right? Because if I cut this bone in half, you'd have a narrow space, right? So you'd have two edges. You'd have the edge that I just pointed out here in the room, okay? Because this is a good analogy for the outside edge. But the inside edge would also have a covering. Now, inside stuff, in doctor speak, we usually like to say endo, right? Okay, and if it's outside, we like to say peri, right? So if it's periosteum, what do you think the stuff on the inside is called? Endosteum, of course. And endosteum has the same stuff. So endosteum has the same things. So endosteum and periosteum are both the living, sort of the vibrant, the active tissues in a bone. So you got the outside and the inside are both capable of adding bone. Okay? So you can imagine there must be some sort of mechanism here where bones get bigger, okay, without necessarily getting heavier. Because imagine that, if you start with a big, like, look at how, you know, obviously this bone, this is an, you know, I guess an adult, almost an adult, not quite as tall as me. I'm taller than this person. But if you look at this as an adult, how do we know it's an adult? How do we know that this is an adult bone? It's big. There you go. Brian hit it. Because when you're growing, all of your long bones are actually 3 bones. So if somebody would ask you, how many bones does a newborn have? Well, they have a lot more than an adult. Because every long bone is 3 bones. Every long bone has 3 parts. Until you're done growing, you've got 3 times as many long bones till they fuse, right? Till they stop growing. Okay? So, bone growth is about surface activity on the outside, which we call periosteo. And surface activity on the inside within the endosteo. Okay? So, let's look at what happens now if we have a bone. Now I'm going to draw like this. I'll tell you what I'm going to do. I'm going to make a new drawing here from the very beginning. And we're going to talk about this bone, this one right here maybe. This one. This one. Okay? But I'm going to make it a little simpler because it's easier for me to draw. Okay? There's going to be one end of this bone. Okay? I don't care which end. One or the other. Then there's going to be the other end of the bone. And then there's going to be the middle part. Okay? So every bone is going to have, these long bones is going to have 3 parts. Okay, so this is the simplest type of bone growth. This is the simplest thing. We can explain it in one hour. Okay? The face is like infinitely more complicated, but the same processes are involved. It's just more intricate because our face is more intricate, right? So the long bones, all the long bones of the body grow the same way. We're just going to take one as an example. So we know that now, instead of looking at the cellular level, now I'm looking at the organ level. So I drew the bone, and then I drew the middle part and the 2 ends. Now you know that the 2 ends have a different name than the middle, right? Okay, so the middle is called what? Diaphysis. Okay, so the middle of the bone is called the diaphysis. And one end of the bone is called the epiphysis. What's the other end called? It gets the same name. I'm just going to cut to it. Okay. I don't know why they don't call it different, but if you talk about things in the body, now this is a weird thing about dentistry. Okay, when we say distal, what do we mean when we talk about teeth? The back, right? Away from the midline. But when you say distal in everything else, distal is the other end. It's away. So just remember that if you're looking at something like this and you're talking to someone that's not in dental school and you start talking about distal, they're going to say the distal one's the one that's further away from the body, and the proximal will be this one, right? So they'll say proximal and distal, and then we just came up with mesial and distal and made it out backwards just so we had our own language. I'm not sure why we did, but anyway, mesial and distal. The distal's opposite way was the medicine. So that's okay. Just within ourselves, we can talk about mesial and distal, and just remember it's different for the rest of the body. Okay? So the epiphyses sometimes are called proximal and distal, just for completeness. Now, let's talk about the diaphysis, which is the part of the bone in the middle. Part of the bone in the middle. We're looking at the bone as an organ. If I now would cut this in half like that, and I would look at it over here. And I'll make it simple, I'll just make it round, and I'll make the center round like that. Okay? In the middle here would be all of you people, all you osteocytes. You'd be all in the middle. Okay? And on the outside, just the outside of the bone, would be the lucky people on the ends, okay, that are in the periosteum, okay? So the periosteum can grow, right? The periosteum can grow. So periosteum can, the osteoblasts grow, and then they become osteocytes as they lay down this matrix, right? And then now, so obviously what's sort of happening is this membrane is sort of getting pushed out, right? Sort of being propelled out by the division of the cells, and it's sort of increasing, and you're getting more osteocytes behind it, right? So you're getting this sort of thing, and when we see that, we call that deposition of bone. So deposition, bony deposition, is the addition of new bone. Okay? Now you can put together your big words. Okay? If this deposition is happening on the outside of the bone, we put the two words together. And we say it's, you're afraid because I'm going to call you the first row now, periosteal deposition. Right? So periosteal deposition, we can now, I can just say this bone's undergoing periosteal deposition, and you'll know what I'm talking about. I'm saying that that bone is growing, and the new bone is being formed by the periosteum. Okay? Now, remember I said there's endosteum too. There's endosteum too. We're going to get to Brian's point here in a minute. All right, so there's the endosteum. So we've got endosteum. And we know that it has the same cellular matrix as the periosteum, so we know it's capable of forming new bone. So we know that also we can have endosteal deposition. So, if we talk about the types of new bone that gets added to, especially long bones, because it's simpler, right? We're talking about just periosteal deposition or endosteal deposition. Now, the other part of the equation is what Brian brought up earlier, okay? We can't just be adding and adding and adding more bone, okay? Because the skeleton would get too heavy. So, the biomechanical nature of our skeleton is that we have the bones become bigger, but they're cylinders. They're not rods. Because for a given weight, a cylinder is much stronger than a rod. A rod's still stronger, but for a given weight, a cylinder is stronger. So, what must happen then in this diaphysis as the bone grows? What must necessarily happen? Osteoclast activity must occur somewhere. Where do you think it might occur? Endosteum, exactly. So the endosteal surface, not only does it have osteoblasts, but it has osteoclasts. And osteoclasts reside in the periosteum and the endosteum. They don't come from the same cell line as an osteoblast. Okay? Where do osteoblasts come from? The mesenchymal stem cells, right? So mesenchymal stem cells, undifferentiated mesenchymal stem cells, can become osteoblasts. They can also become fibroblasts, or they can become lots of stuff. Okay? So the undifferentiated mesenchyme is where we get all the osteoblasts, the fibroblasts, a lot of that stuff, but not where we get osteoclasts. Osteoclasts come from multinucleated monocytes. They collaborate together, and they become a giant cell. And that comes out of the hematopoietic system. I have to get that one's tough for me. Okay, so, but in the periosteum, I forgot to mention that, didn't I? So let's just, like I said, if I leave something out, check the book, okay? Because what we should have put in here was what? Osteoclasts. I was too concerned about getting to the nerve. All right, so we've got endosteal osteoclasts. What do you think they're going to be doing? As this bone is getting bigger on the outside, what do you think is going to be happening on the endosteum? We're going to resorb bone. Okay? So what happens as a long bone grows is, especially the diaphysis here, okay, it grows in girth or width. So all the long bones grow in width like this by periosteal deposition and endosteal resorption. Otherwise, you'd end up with this, too heavy skeleton that wouldn't work. Okay? So all of the bones in general, when they're growing, undergo periosteal deposition and endosteal resorption, we call it. And resorption is carried out by the osteoclasts. So, as far as growth of the diaphysis in width, it's very simple. We get periosteal deposition, we get endosteal resorption, and as the bone grows, we start, it's like an onion, right? We just keep adding bone on the outside, and we take bone out on the inside so the bone can get bigger in girth. Okay, and the marrow space gets bigger, which is handy, right? Because as the organism gets bigger, it's sort of handy to be able to make more red blood cells and do all those other things, right? So it's sort of a well-designed system. So, endosteal resorption, periosteal deposition, that's what happens in the diaphysis in general. In general, that's the pattern. And that way the bone can get bigger around. Now, we've got a problem with bone and bone growth. Bone has a lot of issues. All right, so we need it, but because of its unique structure here with this membrane on the outside, it causes us problems. Because bone, although it's rigid, and it's really good for rigid support, it sucks in terms of resisting gravity. Okay? So resisting gravity is something that we need to do on Earth, at least right now. Okay? So in order to resist gravity, we had to come up with some sort of a system, okay, whereby bone would be the rigid support, but something else would help us resist the pressure of gravity, the weight of gravity. And in fact, something else would help the bones grow in length, because what do we have attached to these bones, like the long bone? You got muscles, right? And the muscles are compressing the ends of the bone. You know how muscles attach, right? There's an insertion, and so the muscle compresses the bone. So the problem we have is that bone in general, if we look at bone, right, it's got this surface covering like this, okay? So it's got the surface covering, and what happens is, if we then put pressure on the bone, we then put pressure on it, like whatever, just any kind of pressure, force, this way, make an arrow like that, some sort of force. What we're going to get there is bone, the periosteum is going to get compressed. When you compress the periosteum, you compress the blood vessels. When you compress the blood vessels, you kill the bone. Okay, so if we compress it a lot, we're going to get necrosis. If we compress it a little bit, the body will respond and resorb the bone. Okay? So bone, we say, is pressure adapted or tension adapted. It can't resist pressure. So that brings us to the second structural tissue that we had. And I said that the second structural tissue was cartilage, and I said, we've got these sort of things like this that's handy, like, you don't break off your ears all the time and your nose unless you get a real solid punch there and you can break the tip of it. But, a lot of things that are made out of cartilage are made there so they're sort of flexible. There's also kinds of cartilage that have specific roles in the body, okay? And one of the roles of cartilage in the body is to be there in areas that are under pressure. Anything that's under pressure. So, obviously, if you're looking at all of the joints, right, every time we have two bones that come together, we have to have something in between there. Sometimes it's pretty complicated, like the temporomandibular joint, or like the knee. We've got some cartilage that's covering the bone, then we got these little cartilage discs that fit in there, and then, so it becomes a complicated sort of a cartilage mess in there, okay? But the cartilage is there to resist pressure. So we always see in bone, anytime there's loading, we're going to see a cartilage. So in this long bone, in general, what we're going to see on the ends here, we're going to have a cartilage cap. cartilage cap. We're gonna have one on both ends. Okay. We're gonna have this cartilage cap. So interestingly, cartilage has a matrix too. Okay? But it's not a calcified matrix. It's an amorphous matrix. It has a lot of water. It's sort of a squishy matrix. Okay? And it's made up of collagen number 5 and all those things that you learned about in biochemistry. I mean, all those things that have these properties that they can resist. So what happens in cartilage is we get these cells, okay, but then instead of secreting a rigid matrix, they secrete a flexible matrix. People call it amorphous ground substance, made up of proteoglycans, things like that. So, the key to the matrix in cartilage, from a physiologic standpoint, is that it doesn't need to be vascularized. You can nourish chondrocytes and chondroblasts by diffusion through the amorphous ground substance. So cartilage doesn't need a covering. Cartilage doesn't need blood vessels that can be compressed. Cartilage can live by diffusion. Okay? Make sense? So we see cartilage where we see areas that are under compression. And when we look at this histologic, have you had histology with Dr. Chandler? Okay, so when you talk about cartilage, and he talks about fibrocartilage, and he talks about hyaline cartilage, and he talks about growth cartilage, and he talks about all these different cartilages, okay? Realize that actually the difference is not the cell. A chondrocyte that's in articular cartilage, and a chondrocyte that's in growth cartilage, and a chondrocyte that's in fibrocartilage, and a chondrocyte that's in anything that has the name cartilage in it is the same cell. It's hard, I mean, this is one of those things where it gets confusing when you're a student because you don't know how to put everything into context. What Dr. Chandler is talking about is the way it looks under a microscope. That's what makes hyaline cartilage different than growth cartilage, the way it looks under a microscope. It's not different cells. Okay? So imagine now, we talked about how you could put things into a context where they sort of make sense. Okay? If I was going to design a cartilage that would be really effective in areas of articulation, would I want lots of cells and just a little bit of this squishy ground substance? Or would I want just a few cells and lots of squishy stuff?
More cells?
Why more cells, you think?
It's denser.
It's denser, okay, that's a good, it's one of those things, that's right. But what happens is, exactly, it is denser. What happens when you put the cells together, they don't have so much cushion. It's like, imagine that it's like the princess and the pea, right? You know, you put the cell under a stack of mattresses, which is the ground substance. The more ground substance you have, the less the weight on top of that, compresses the cell. But it is denser, you're exactly right. But it's a question of how much give it has. So if it has more give, then it needs more amorphous ground substance. So hyaline cartilage, which is what we call the articular cartilage. Hyaline cartilage and articular cartilage, same thing. All right, same thing. Hyaline means cell-free. Okay? Remember when did you look under the microscope? You don't even use microscopes anymore. But remember when you looked on the computer screen and you looked at hyaline cartilage and they said it looks like ground glass? You remember? I don't know if they do still do that, but they said it's ground glass because there's not many cells, that's why. Still cartilage, but it looks like ground glass because it's a lot of amorphous ground substance, just a few cells. And that's the kind of cartilage that we have in the articular areas, which means on the end of the bones. Okay. Now there's another really, really important cartilage that we have, and especially important since this course is called facial growth, because it's called growth cartilage. And the growth cartilage now, the growth cartilage is stacked, like stacks of coins. Stacked up here, stacked up. These cartilage cells are stacked. They're directional. They're arranged, And if you remember when you looked at your computer screen, they said look for stacked coins, right? That's how you identify, I don't know if they still say that, but that's, anyway. I used to teach histology, that's what I used to say. That if you're looking at articular cartilage, you look for the cartilage that's stacked, right? It's got an arrangement, as opposed to like cells are sort of all over the place. And the reason is that growth cartilage has lots of cells, because the idea there is the cells want to divide, and when the cells divide, guess what? They have a potential. When cartilage cells divide, they can resist pressure. In fact, they can exert pressure. They can exert pressure. They can exert pressure against the muscles. They can exert pressure against gravity. And when they do this, they can actually increase the length of the bone, even though there's pressure on the bone from muscular attachment and from gravity and all those things. The cartilage cells are strong enough, it's powerful enough. The epiphyseal growth plate or epiphyseal growth cartilage is powerful enough to resist these tremendous forces. So it's the division, and it's the interstitial division of cartilage, because cartilage can grow interstitially. So it's the interstitial growth of cartilage that creates the force that actually moves the bone and causes the increase in length of bone. So the increase of all long bones, every long bone has an epiphyseal growth plate, and the epiphyseal growth plate, the purpose is to divide, to push the epiphysis away from the diaphysis, and then there's a process that occurs, because imagine what would happen, I'm pushing this away, right? And I'm just going to do it on one side, but I'm pushing it away. And when I'm doing that, the epiphyseal growth plate is getting really big, right? So imagine, there must be something that's happening, because otherwise you'd have these bones like this, and when I showed you the bone, it would have this huge cartilage piece in the middle of it, but it doesn't. So that cartilage, as it increases in size, gets turned over and changed into bone. Okay, so at the interface here, between the cartilage and the bone, there's a process whereby cartilage gets transformed into bone. Okay, and that transformation, that change like that, is called endochondral bone formation. Endochondral bone formation. Endochondral bone formation means bone that was once formed in cartilage and then converted to bone. And it happens at all the epiphyseal growth plates. Make sense? Now, what's interesting, and this is, how many people have kids? Anybody? Nobody wants to admit it? All right, so I do, I have kids. All right, but if you have kids, you may, and if you don't have them yet, then it's okay. You can just put this away for later. Okay, so remember the periosteum? The periosteum sort of goes around the whole bone, even around this growth plate, even that, okay? And what happens when the epiphyseal growth plate pushes the epiphysis away from the diaphysis, it stretches the periosteum. And when it stretches the periosteum, obviously we know from Brian's experience that there's nerves there. So when that periosteum stretches due to growth of the epiphyseal growth plates, kids have growing pains. It's a real thing. It's a real thing. So if you have children and when they're in their very rapid period of growth, and if you don't have them now, maybe you will, it's your choice. But it's a lifetime commitment. I don't know. Don't do it lightly.
Hopefully it's your choice.
Yeah, hopefully it's your choice. Yeah, that's true. Nowadays, it's someone's choice. But anyway, when these kids go to bed, I can tell you, if you're a parent, there's going to be a night that your son or daughter is going to wake you up, and they're going to say that they have pain in their legs, because it's always in the legs, because they have the biggest bones and the biggest periosteum, and they're going to hurt, and it's real pain though. It's not, they're not screwing around, they're not pretending. It's stretching of the periosteum, and probably you telling them that's not going to make it feel better. But you can tell them it's going to get better when they're done growing. So the epiphyseal plates displace the epiphysis away from the diaphysis, and the key for you today is to, in the learning objectives, is to know how this bone grows, okay? And the gist of it is this: it grows in length by growth at the epiphyseal plates, and it grows in girth by surface activity, periosteal deposition, and endosteal resorption, and that's the end of that story, okay? So, with that, let me show you a couple slides. I got 2 minutes left. You don't have anything after this, right? And I don't want to take a break and then come back for 5 minutes. So let's just, I'll try to get the computer working, and then while we're waiting for it to let me see what I need to do. Power. Project on. All right, while I'm waiting for that, questions? Yes? Okay, good question, and somebody's getting ahead of me, but that's a good question. Julie had a good question. Endosteal, in the long bones, it's endosteal resorption, we said that. But in fact, as we start to talk about facial bones, and as we start to talk about how, you know, bones heal and all those things like that, the endosteal portion can also undergo deposition. And, surprise, surprise, the periosteum can undergo resorption. So it's actually always going to be, both are common, but when the long bone is growing, it's the width by periosteal deposition and endosteal resorption. But you're exactly right. The same cells are there, it's just different signals that tell the bone to do something different. Oh, it looks like we got something. Looks like it's not mine, but that's okay. See if I do this. It says wait till the projector's warming up. It's almost done warming up. You know, I looked at those little chapter summaries from that other book. I'm not sure how useful those are. I would focus your studying on the little videos that are good, okay, and then the big chapter if you want more stuff. I looked through everything and I thought, I'm not sure that's not more confusing. Let's see what's happening here. Okay, it says it's there. So
this is cartoon.
Laptop.
The cartoon food looked delicious.
HDMI in. Oh, cool. Okay, here we go. So this is, and by the way, Heather did post my slides up for you to use, but anything of a patient, please don't like Facebook it or something crazy like that, right? Because these people didn't give me the permission to put their name on the internet. They just said I could use it for teaching. So bone and cartilage are structural tissues. The key is this. If that little thing right here is just like an osteocyte, right? Well, right now it's on the edge, right? So it could be an osteoblast even, okay? But however the bone is, I can add more cells on this side, and I can take cells away from here, but this cell's still the same cell, you see that? So that's why, how people study bone. They study it by giving people what they call vital dyes, which stains the cells, right? But only if you kill the person and section the bone, so we usually don't do it. Okay, but if you ever took tetracycline when you were younger, because you know when your bones were growing, you probably have a brown line in your bones, right? But this was done in pigs and rats and things like that. But basically, they labeled with different colors and with different dyes. Alizarin is the big one; it's red. So they would inject this, and then all the cells that were forming at that time would be stained red. So if you injected the alizarin at this point in time, and then time is going up this way, that cell would be stained, and then you'd see that more bone was added on here. Because just by looking at an x-ray, you can't tell. Right? You got to have some markers. Some markers. Okay, so that's the idea of this slide. This gets to Julie's idea, and that is that if we look at the bone now, you can see this is what, if this is being, this is undergoing deposition. I don't know why there's a negative sign there, but this is undergoing deposition. Is that a 1 or something? I don't know. But let's just say this bone is drifting this way because we're getting bone added on like that. We call that periosteal. And then here we're getting resorption, so we're getting end osteo resorption. But here we're getting Julie's idea, right? End osteo deposition. And here you're getting periosteal resorption. Okay, so those are the pieces, parts that you need to know. If you care at all, and you look at an actual radiomicrograph, and I'm sure you don't care, but I'll show you anyway. But if you look at this, you'll see that, in fact, you can see on this bone where the bone, you see where there's a line there, and you see this, where it's sort of all filled in and it's all like whirling around like that. And the little black dots are where the osteocytes used to be. Because when people make these things, what they do is they take the bone and they grind it till it's thin enough to put on a microscope. And then you look at the light coming through. And so when you're looking at it, every place that you see a black dot is where a cell used to be. And every place where you see white is where the deposition is. And you can see how it comes, you can see lines there, and so it's like a tree, like people can look at bone growth, and that's how actually we figured out how the whole body grows, but especially the face, by looking at these ground sections and figuring out if it was deposition or resorption, what was happening. You can imagine how would you get something like this, which is all goofy, right? It's all swirling like this. That's what endosteal deposition really looks like in the microscope. Because you know how the endosteum is sort of, it's not just a circle like I draw it, right? It's got like little lamella and all that kind of stuff. So when that fills in, it fills in like this, right? It fills in until you get to the center. So when it fills itself in into this whirling sort of pattern. And that's how you can tell the difference between endosteal deposition. Periosteal deposition looks just like onion skinning, it's just like one layer on top of another on top of another. I think that's it. Let's see here. Oh, no. Okay, so I just said this. What's this? Periosteal deposition, periosteal deposition, See how it sort of lines up like a line, and then we'll talk about what these babies are later. Okay, these things. What are those things? What are those things? Anybody know? They're not lacunae, but what they are is osteomes. Okay, and remember we talked about how unfortunately some cells are going to die in the middle of the bone. And we can either let them just rot there, or we can have some mechanism. But actually what happens is when those cells, just the three of you, maybe even a couple people to the side, when those cells pass away, because they have a limited lifetime, right? So cells only live so long. So if they're in the middle of the bone, we've got to have some way to get in there and get rid of them, okay? And so for a long time, people didn't know what these things were in bone. We knew we didn't see them until people got older. We didn't see them in babies. We didn't even see them in young kids. We just saw them in older individuals. We saw these weird target-shaped things. And then somebody did some work on this, and they discovered this thing called a cutting and filling cone, which is a rotor-rooter sort of for bone. And look, it's centered. It has a blood vessel in the center. It's got a head of osteoclasts, okay? And then it's laying down bone. And believe it or not, if you cut through it here, all you see is the resorption cavity. If you go in here, you start to see this. And what do you see here? The osteome. So it turns out that these things are caused by bone turnover. And we use bone turnover for calcium metabolism, right? Calcium homeostasis. Everybody remember that? Remember the calcium gate? You got to keep your calcium at a certain level. Otherwise, the gates don't open and you die. So it's sort of important. And so you've got these things like this, and this is how you both deposit bone, you can deposit bone, and you can resorb bone. It's the same sort of thing. It gives us bone turnover. Now, just as an aside, what's very interesting for dentistry, and we're going to end with this, what's important about this cutting and filling cone for dentistry is that many of you have probably heard about dental implants, okay? And you've heard about how, the future of dentistry is going to be dental implants and all those sorts of things. But dental implants are titanium. And we drill a hole in the bone, and we put this piece of titanium in there, and then we suture it up, and we leave the titanium in there. And lo and behold, what happens, it becomes part of the bone. Okay, we call it osseointegration. Now, the way it osseointegrates, now you know. It osseointegrates because we kill just a little bit of the bone around the implant when we drill in there, and that signals these cutting and filling cones to come into that implant area, and they go around the implant, and as they go around the implant, they connect on one side the titanium and on the other side the living bone. And if you screw up, you see it's only 160 microns. So if you kill too much bone when you drill it, it doesn't integrate, because you can't span that much with a cutting and filling cone. So the reason why you're irrigating, you're trying not to kill the bone, is because the cutting and filling cone is only 160 microns, and you don't want to kill more than that, okay? So that's the dental implication for this that you could carry on throughout your whole life. Okay, any other questions? Yes?
How does bone graft end up applying?
Okay, bone grafting is a totally different thing. Bone grafting, when you do a bone graft, basically what you're doing is you take bone. Usually we'll take it out of the hip when we do a bone graft here in the mouth. But we usually, what we do is we scrape out the marrow of the bone that has a lot of blood, okay, and it has some bone spicules, and we put it in an area. And then actually what happens is the osteoblasts from the periosteal surfaces that are next to that grow into that, and it forms a scaffolding. So it actually, bone grafts are not ever part of your body. They just form a scaffolding because osteoblasts can't jump, okay? So we can't have bone can't jump. That's why when you have another thing is like if you break a bone, you know, if you break a bone, what's the one thing you gotta do to get a bone to heal? Split it because no movement. So the two things you need to get a bone to heal are the bone has to be touching other bone and it can't be moving. Why? Because osteoblasts can't jump. Okay? And if you get movement, then you get cartilage or you get fibers because, bone's rigid. So if you break a bone, you fix it, and then you make sure the bones are touching. And if they're touching, they're going to grow together. And with the graft, a lot of times you have a gap, right? So what you do with that is you're now putting the graft material in that gap, and then it'll grow into that.
So with that said, why is it better to have the self-grafts versus the cadaver grafts?
You know what? I think that because people got really worried about AIDS, we were doing a lot of cadaver grafts, and then the AIDS thing, there's somebody got, there was a problem, they didn't have a good screening technique, and there were some people that, were worried about that. As far as I remember, nobody ever had a problem. But it's just some people like that's, because.
So if you use the bone graft, you still have to follow the 160 micron rule?
Pardon me?
If you use the bone graft, you still have to follow the
No, if you use a bone graft, then that eliminates this.
Okay, so you're not-
But then you gotta have bone on both sides. You can't graft an implant. You have to have bone on both sides. But it's a good question. Yes.
Well, exactly. What?
Jacob's got a question. Let me just
If
answer.
you hear people talk, usually the cow bone's about 6 months, and then the cow graft is like 6 months,
Yeah.
and then the cadaver is like 3 months. Self is like